Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, I would like to talk about caring and sharing because it's so important. Email me. I'm loving it, guys. I am really loving it. All the emails, and it lets me know exactly where you are out there with your health and what we can do on this show to promote good health for you. Remember, www.medmoments.com. Don't forget the S now, medmoments.com. Or tweet me at medmoments. Well, I want to do a little let's talk, okay? Because this is an important topic. I want to talk about cancer screening tests because there are certain cancers that we just have to screen for, because if we can determine that you have current cancer or early detection, that means so much as far as survival is concerned. So let's go through a couple of these cancers. We got breast cancer. As far as breast self-exam, that should start at 18 years old, and each female should do it once a month. You really have to do this. Mammograms for your breast should be done at the age of 40, and you should get a mammogram each year. Stool occult blood tests, and this is looking for colon cancer, and at the age of 50, you should do it once a year. Colonoscopy. Colonoscopy is that procedure that they look in the colon and they try to figure out if everything's normal. That's looking for colon cancer as well. At the age of 50, you should have this done every 3 to 5 years. And pap smears. Pap smears for females should be done every year. That's very, very important. Looking for things like cervical cancer. And then we have the digital rectal exam, and this is for men. Prostate cancer is real, guys. You have to get checked by your doctor, and you should have this done every year, and it should start at age 40. And then skin cancers. Skin cancers are real too. So if you find an abnormal growth or a pimple that doesn't go away or a growth that changes color, you have to let your physician know. Remember, early detection is very important. All right. Well, as far as our topic for tonight, our major topic, and it's one that's very exciting as far as I'm concerned because I see so many patients in my office that have this problem. It's hypertension. But today we're going to take a little bit of a twist. We're going to talk about hypertension. We're going to cover it generally initially, but then we're going to focus on the African American and why that population of patients have hypertension. I have the perfect person to talk about this particular topic. His name is Dr. Lawrence Bird, and he is Chief of Hypertension at St. Barnabas Medical Center. Dr. Bird, welcome to the show.
Welcome, thank you.
All righty, definitely. I'm so happy that you took the time to come on the show because this is such an important topic. You know, I always start off with the most basic question. What is hypertension or high blood pressure?
The way I would put it is high blood pressure represents a level of blood pressure that is too high for the body and therefore damage occurs. The number we often use, and I think it's still probably the best one, is 140/90.
Okay. So 140/90 is normal blood pressure, or is that if you tip over that, then it's high?
Exactly right. If you tip over that, you're now in a range where there's potential danger.
Okay. So, and let's just step back for a minute because I just want to explain, because it's so important and so many people have it, I want to make sure that everybody understands. Tell me what's the difference and what does it mean to have the top number and the bottom number? What is that all about?
Exactly. The top number we call systolic. In a sense, that means what's the pressure during the heart's contraction when it's pumping fully, as opposed to the diastolic, the bottom number, and that's the number we talk about when the heart is relaxed briefly when it's not pumping.
Okay, so when they're listening, when your doctor is, or you or me or another doctor is listening to a patient, we're listening for when that heart contracts and pushes the blood out into the bloodstream.
Right.
And you hear it.
And exactly. When you or I are listening with our stethoscope, we're listening for this little tapping sound. When that sound begins, that's what we call systolic. When that sound disappears or gets muffled, we call that diastolic.
Okay, so that's the top number and the bottom number.
Exactly.
And everything in between, long as it's between that 140, you said 140 over 80, you said?
I'd say 140 over 90 is
over
probably
90
a
now.
good divider.
A good divider. And long as it's below those two, the top number is below 140, the bottom number is below 90, we're good.
Exactly. I might say one thing about that. Many people, particularly experts in care of African Americans with high blood pressure, would set that number lower.
Okay.
So there are people, there's an expert, Jack Flack in Detroit, for example, would say, gee, guys, you ought to be 135 over 85. So the number may vary a little depending on who you consider the authority.
Okay, all righty, okay. What are some of the symptoms that a patient that has high blood pressure would experience so that they'll know, well, I better see my doctor?
Right. Well, the interesting thing is, the symptoms that are the commonest are things like headache, a lot of times in the back of the neck or in the back of the head, sometimes dizziness, sometimes chest discomfort or shortness of breath. But the scary part is that most people with high blood pressure do not have symptoms, simply don't know it. And so no matter what one's racial background is, many of us have no clue we have high blood pressure until it's very, very high and somebody discovers it.
Okay, all righty. And if you're at home, and you may have high blood pressure or you may not, and someone happens to take your blood pressure and it's very high, what should you do at that point?
First thing you've got to do is get to a physician. Okay. First and foremost, if you have a primary, get there. Right. Let them screen it. And remember that blood pressure is a dynamic variable, so a single reading isn't a diagnosis. So whether you're at home and a friend takes it, or a relative, or even a doctor or a nurse practitioner, one reading's not enough to make the diagnosis. So it takes multiple readings.
So you're telling me if I'm home and my son is running around the pool like a nut, and I'm afraid he's going to fall in the pool, and I'm screaming at him, "Don't run!" Guess what? My blood pressure is going to go up.
Exactly right. Exactly right. So a single reading when you're under stress doesn't mean you have high blood pressure.
All right then. Okay. Risk factors. Are there certain things that we do as individuals that would increase our chance for having consistent high blood pressure?
Absolutely. And they're the things that probably all of us are at least somewhat aware of. Being overweight, being inactive physically, no exercise, being diabetic, being African American itself is a risk factor because the chances of having high blood pressure are much higher. So all of those things, having a high salt diet, drinking alcohol in fairly large quantities, like 2 drinks a day or more, all of those things.
Is there a particular age that blood pressure comes on or blood pressure will elevate more than another age?
It's a good point. The fact is, high blood pressure can start at any age. So I actually have seen, there are pediatricians who see kids with high blood pressure. Unfortunately, I've seen more and more adolescents, teenagers, kids 14, 16, 18. But for most people, it starts somewhere in the 20s to 40s. And just as you pointed out, the age of about 50, 55 is when all of us start to experience a rise. So even if we've had great blood pressure, by about 55, our top number especially starts to go up. Our bottom number levels off and sometimes falls even. But after age 50, it's the top number that matters most.
And do most of those patients require medications at that point when it starts elevating like that?
Many do. So if you look at people by the time they're in the 60s or 70s, most of us have high blood pressure.
Interesting. Very interesting. All righty. Okay. As far as race, I know that race plays a part. Is it a huge part? I mean, is it? Do we make more of it than it really is?
You know, I think we don't. In fact, I think we almost need to make even more of it because Hypertension, high blood pressure, is not just more common in blacks than whites. It's a more devastating disease.
Oh.
It starts earlier. It gallops faster. So we talk about something called pre-hypertension, meaning you're sort of getting towards it. It accelerates faster in blacks than whites. And once it gets to be for real, where it actually is high, the complications are so much higher. For example, my specialty was always kidney disease. We see way more kidney disease. If you look at things like people who are on dialysis, there's 3 to 4 times more blacks than whites on dialysis. Wow. It's very scary. There's 3 times.
And that's secondary. You feel most of that is secondary to blood pressure?
Most of that is driven by blood pressure.
Wow.
Similarly, congestive heart failure, where your heart's not pumping well, you get admitted to the hospital, legs are swollen, short of breath, 3 to 4 times more common in blacks than whites. Stroke is 3 times more common in blacks than whites. So all the things we're trying to prevent are way more common if you're African American.
Interesting. Goodness. What's the typical patient that has high blood pressure? How do they present to your office?
The typical patient is somebody who probably has already been seen elsewhere, probably has had difficulty with controlling their blood pressure, and that's how they got to me, because high blood pressure can be cared for by many, many people.
Right. So what you're saying is that in your office, and it was sort of a slanted question because you're a hypertension specialist.
Right.
So they're not going to. Usually, a primary doctor is not going to refer you the mild, the occasional
Exactly
elevated blood pressure. They're going to refer to you that patient that is very difficult to treat.
Right. So the classic person who walks into my office says, "Doc, I've had high blood pressure for 5, 10, 20 years, but I'm on 4 medicines now. My blood pressure is not good enough. My doctor said, come here because we need to find some answers."
Okay. Can blood pressure kill you to the point where you understand what I'm saying?
Absolutely.
Can being out of whack just
unfortunately,
be your demise?
Unfortunately, it can. And the old thing we all heard about in school, the so-called silent killer, is absolutely true. Some of us have symptoms, some of us don't. And in a way, being silent is dangerous.
Right.
Because we don't get the message, gee, something's wrong.
Interesting. All righty. So just give me an idea. I read something that only 46% of patients out there with high blood pressure are adequately controlled or controlled properly. And that seems to be an awful high number.
It is absolutely true, and the reasons are many. Part of it is access to care. A number of people just either don't have insurance or have limited coverage. Okay. Many people have other problems that may outweigh things, so that they may have difficulty even affording the medication.
Right.
And one of the responsibilities we have is to say, listen, is this too expensive? We shouldn't assume anything. Right. The medicine may cost $10 a month. That may be $10 too much if you're choosing between food on the table for the kids and the proper medicine.
Right. Let's talk about certain disparities.
Yep.
All right. Things like social disparities. It's certain areas where you may live, there may not be a pharmacy close, or if you're a senior, there's nobody to get. Are these some of the things that you see in your practice?
I absolutely do, and it's something we as a country have to do better at. Hopefully, Obamacare is going to help solve that. We hear a lot from one side of the political spectrum that says, oh no, it's terrible. It's not terrible. Right. It's giving people access to care who never had it.
Right. What about as far as economic? And you had mentioned this briefly. You had touched on it. It's a big part of the, controlling the blood pressure.
Exactly. Unfortunately, this is life in America and in the world. Economics does dictate a lot of things. The good news is we have medicines now that have been around. Many of them are generic, are less expensive. We can work with what we've got. We've got the tools. When I started in this 40 years ago, we had very few tools. They were lousy. The side effects were terrible. Now we've got a lot of medications which are affordable, don't cause side effects, and work well.
They work well. Huh? Now, do they work well across all, should I say, different cultures and different, not cultures, but different races, I should say?
Yes, and the key there is any of us with high blood pressure, there are general rules.
Right.
And the fact of the matter is, some patients respond better to certain medicines than others. So, for example, African Americans are said to respond better to water pills, to something called calcium blockers, but any medication may work well in a given individual. So, as in life, generalizations only go so far,
Right.
and we have to see what works in that individual.
Right, right. Now, and one thing I just wanted to say, you had mentioned it, that African Americans have a greater, I should say, end organ damage.
Exactly.
All right, end organ, and maybe you can
Exactly.
explain what I mean by end organ damage because of the
Right.
high blood pressure.
Right, so important. The organs that really take a hit, that get damaged by high blood pressure, the brain, stroke. None of us wants to get a stroke.
Right.
Nobody wants to wake up not being able to communicate with their loved ones or dragging a leg. The heart. The heart can get enlarged very early. There are some studies from Philadelphia and Detroit showing 13 to 16-year-olds, even with just high normal blood pressure, 40% of them may develop a thickening of the heart muscle,
Wow.
which leads to failure later.
Okay.
Terribly risky. The kidneys really get hit hard. We talked about that. So these are organs that we've got to be concerned with, and they unfortunately hit the black population harder than whites, Asians, or any other group.
Right, right, right. I know there were certain, for instance, sarcoidosis is something that I take care of, and it affects the eyes. Does blood pressure affect the eyes as well?
It does, and one of the ways we can check it out easily is your doctor can look with an ophthalmoscope directly into the retina, can see blood vessel changes that tell us this person's in potential trouble, we got to get on the stick.
Wow, wow, wow. Now, do you find that certain cultures, and I know you've been doing this a long time, so, and you have a large population of many different, cultures
Right.
as well.
Right.
Do you find certain cultures, when you see that person, you know their background, they may be a little resistant to taking the medication, or you know what I mean? Well, my brother over here, he tried that, and do you get that very often?
I do, and with respect to that, I think it transcends race or other demographics. Blacks, whites, Asians, we've all heard some kind of horror story somewhere along the line, whether it's blood pressure. Oh, my cousin, my friend had a side effect. The fact of the matter is, we've got the tools, we've got good ones. Don't listen to the stuff you hear on the street,
Right.
because everybody's heard a horror story.
Right,
the
right.
fact is, we can find things that work.
All right then. So, and this is a type of disease, and I'm going to just say that I feel that you have to take the medicine on a regimen. You know what I mean? You can't miss it. And how do you get your patients to buy into that?
You've got that so right, nailed. This is not a disease or a condition where you can say, gee, my pressure's high today, I'll take my medicine, or I'm going to take it this week but not next week on vacation. This is one of those times you have to decide, look, I have this. It's like I'm not a little bit pregnant. You either have it or you don't.
Right.
You can't decide that Tuesday's good for medicine and Thursday's not.
Right.
You got to get into that routine. Took me a while, but you got to say, I'm taking my medicine every day. I'm taking it in the morning with my breakfast, or I'm taking it with dinner, or at bedtime, but I'm taking it every day.
Right. All righty. The thing of it is that as far as other diseases and other organs, in getting it under control, do those organs that it usually hurt, do they do better in the future because you kept your blood pressure under control?
They sure do, and that's so important to emphasize. If you keep your blood pressure well controlled, you can avoid all of that. These are avoidable things, preventable. Stroke, heart attack, congestive heart failure, eye damage, all of it can be prevented. all it takes is just staying on top of it.
Oh, excellent, excellent. Now, cholesterol.
Yeah,
That's one of those bad words too.
right.
All right. Does it have an effect on cholesterol? Because I know this is something that everyone's talking about trying to get down because it clogs up those arteries.
It sure does. And your point's a good one. I can't say that high cholesterol raises blood pressure necessarily or vice versa. They're important to recognize and to treat because together they don't mix well. So if you've got both of them, you're at greater risk to get heart attack, stroke, and so on.
Right.
If you've got those plus diabetes, your risks go up again.
All right, I got you. Now, I don't know if I asked you this, but is it more common in women or men? Either one?
It's about equal, so it's pretty similar. We sometimes think somehow women aren't going to get it as much. They do. And one statistic that's scary, 50,000 black women died of blood pressure elevation alone in the U.S. last year. So this is a killer of a lot of people.
Right. Now, diet. This is the biggie,
What none of us want to hear.
Yeah. Obesity. How do we connect that to high blood pressure in a sense that if you're obese, are you 100% likely to be hypertensive or have blood pressure, high blood pressure?
Good point. You're not 100%, but your risk is much greater. I have an old mentor and colleague from Philadelphia who has studied African American teenagers for years in Philly. And it's very clear. One study she did last year shows if you're black, a teenager who's also obese, your risk of developing high blood pressure is much greater. Your risk of having an enlarged heart is much greater. At 15 or 16, you're already on the wrong path. Wow. So it's the old story. You don't want to let that happen. You want to stay slim. You want to exercise. You want to watch the high-calorie drinks we all drink.
Right.
And stay clear of that.
Alrighty. So the programs in the schools that they're talking about as far as, eating right, making sure that the kids get a proper diet and not a lot of junk food or whatever, that's the key.
It is the key. Michelle Obama has been going around the country emphasizing it. She's hit on something that everybody needs to know about.
What about genes? If mama has it, do I have it? Or if daddy had it, will I get it? How does that work?
Genes are very important. And I don't care what someone's skin color is, black, white, anything. If our mom had it, if our dad had it, it's more likely for us to get it. If they both had high blood pressure, the chances are very high. So we've got to pay attention. You want to ask Ma, you want to ask Pop, did you have high blood pressure? Do you have it now? It's important for us.
All right then. All right. Now, is high blood pressure a problem in pregnancy?
It can be, and when it is, it can be devastating. So it's very important. Obstetricians watch it closely.
Okay.
You women who've become pregnant, your doctor's carefully watching that, and if it becomes high, got to pay close attention.
Right. It could actually hurt the baby.
It can hurt the baby. It can hurt the mom.
Oh, all right. Prevention. All right. I know it's out there. We know that it's a bad problem. What can we do about it?
It's the old story, back to basics.
Okay.
You want to stay physically active. You want to keep your weight down. Diet, you mentioned, so important. Diet, calorie restriction, plus you want to restrict sodium. Do you have to go out and count all the calories at the supermarket? No. Avoid fast foods. Don't use a salt shaker. Less ketchup, pickles, cold cuts. If you can do that, stay away from the Big Macs, stay away from Kentucky Fried Chicken, go to the salad bar.
Are you kidding me? No Big Macs.
It's a tough one, but it pays off.
Okay.
Plus, it turns out we've emphasized sodium so much, it turns out potassium's important. So you want to stay low in salt or sodium. You want to increase potassium. Fresh fruits, fresh vegetables, very important. And it turns out studies have shown that's even more important in blacks than whites.
Oh, really? Oh, okay.
So bananas, oranges, grapefruit, great.
Great, huh? All righty, we're going to have to get with those things. Some other things that we're talking about, because I know we're winding up here. We only have a few moments left.
Right.
As far as treatment is concerned, and I don't want to get into the medications and because that's our deal.
Right.
But what patients can do, and let's just reiterate some of these things. Exercise.
Exactly.
Important.
Stay active.
Right.
Watch your diet. Keep your waistline as trim as you can. Watch the sodium. Watch the potassium. Alcohol. If you're drinking alcohol, if you're having a couple beers, seems harmless, it's going to raise your blood pressure.
Okay.
All of that. And over-the-counter medicines like Aleve, Advil, Motrin, those can raise blood pressure.
Interesting. What about smoking? We didn't touch that. That's a big one.
So important. You see it every day because you see the consequences. Smoking can raise blood pressure, can lead to narrowing of the kidney arteries, which can raise blood pressure, cause coronary disease, lung disease. If you guys are smoking, stop now.
Right. All righty. And what about as far as increasing things like fiber and stuff like that? Does that help?
It does. It absolutely does.
Okay.
Simple stuff. Metamucil,
Right.
fiber in the diet.
Okay. Dr. Bird, thank you very much. We've run out of time. It was
Thank
great.
you.
Great. All righty. So, in closing, remember, sharing and caring. www.medmoments.com. Email me. Want to hear from you. And at MedMoments. Remember the S, MedMoments. Tweet me. Okay. Never institute any change in your medical therapy until you consult your doctor. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.